We now request Dr. Shrinivas Joshi to give his talk on vitreoretinal intersurface disorders.
Yeah.
Yeah, a warm welcome. Good afternoon, everyone. Thank you, AIOS and Dr. Santosh Honavar, Dr. Namrata Madam for giving this opportunity. So I'll be covering about the vitreoretinal interface disorders. Just to touch base upon for our dear postgraduates, you know that 80% of the eye volume, it's approximately around 4 ml, composed mainly of 98% of water and 2% of proteins. That is type 2 collagen and type 9 collagen. These are the important things you need to remember. So what's the vitreoretinal interface? It's basically a complex anatomical structure that is formed by the union between the retina and the vitreous, and the posterior vitreous cortex densely packed by the collagen type 2 and firmly attached to the ILM, that is type 4, that is the laminin, fibronectin and the proteoglycans. Now when we say aging of the vitreous, what do we call it as? Synchisis is nothing but liquefaction of the vitreous, and syneresis is contraction and the collapse of the vitreous body. So look at these figures, that is the synchisis is the liquefaction and the syneresis is the contraction and the collapse of the vitreous body. Now coming to the normal PVD versus the abnormal PVD, first coming to the normal PVD, there are 4 stages. That is stage 1, you can see here. It's a perifoveal vitreous detachment. Stage 2 is, can we have the laser? No, I'll use it here. Stage 2 is the vitreofoveal suppression with a macular PVD. Stage 3, what you can see here is the vitreous detachment from the macula and the mid-peripheral retina with a residual vitreopapillary attachment, and stage 4 is the complete PVD. So when do we call it as anomalous PVD? When there is a persistent attachment of the vitreous at the macula and the rest of the vitreous has detached, featuring an anomalous strength of adhesion to one or more structures in the posterior pole. So anomalous PVD, what all it can cause? It can cause vitreomacular traction, epiretinal membrane, partial thickness macular hole or the full thickness macular hole. When we call as VR interface, what all we need to cover? Important things you need to mention in your exams is the anomalous PVD, vitreomacular adhesion bar traction, that is VMA and VMT, epiretinal membrane, full thickness macular hole, macular pseudo hole, and macular edema with the TPH. Now, of all the classification, which is the more practical and important classification which we need to know is the International Vitreomacular Traction Study, that is IVTS, classification system for VMA, traction and macular hole. So when do we call it as VMA? When there is elevation of the cortical vitreous above the retinal surface in the prefoveal area, but the persistent vitreous attachment to the macula, which is more than 3 mm radius from the center of the fovea. So this is the VMA, vitreomacular adhesion, because there is no traction yet. And how do we classify vitreomacular adhesion? According to IVTS study, again it is, if the focal, if it is less than 1500 micron, and broad if it is more than 1500 micron. So in these cases, usually no intervention is required. So when do we call it as vitreomacular traction? When the elevation of the cortical vitreous above the retinal, that is persistent vitreous attachment within 3 millimeters from the center of the fovea, and there is presence of foveal changes in the foveal contour. Whereas in vitreomacular adhesion, there is no changes in the foveal contour. So this is how you see a vitreomacular traction. So what are the symptoms? Sometimes the patient might be asymptomatic, sometimes he might have decreased vision, micropsia or metamorphopsia. So what the clinical features usually described by the patients are distortion. What we see on the fundus examination is the distortion of the fovea, blunted foveal reflex, cystic changes, and in very severe cases we might even see subretinal fluid. So again, VMT is again classified in the similar way as VMA. Is focal if less than 1500, broad if it is more than 1500. Now, what are the different types of tractions or profile in VMT? They have described as V-shaped and J-shaped. So, grades of VMT based on the OCT, grade 1 is basically foveal distortion, grade 2 is intraretinal cysts or cleft, grade 3 is the elevation of the foveal floor, which might or might not have a subretinal fluid. Now, if you see the D here, the white arrow marks the site of the vitreous attachment. The area of attachment is around 1500 or less than that. In focal VMT, you can see here the focal is with the intrafoveal pseudocyst-like appearance here, And in the F, we can see the area of attachment is more than 1500 micron and is associated with distortion of the foveal surface and elevation of the foveal floor. Now, what is the course, natural course? Most of the times they say that from 3% to 53%, VMT might have a natural course that is spontaneous and complete resolution, suppression, resolution of signs and symptoms, or the patient might have progressively increasing symptoms with increasing CME on lamellar or the full thickness macular hole. Now, this is our own case where you can see here there was a VMT, and when observed, you can see there is a vitreous detachment happening, and the foveal contour is restored back. Not all OCT diagnosed VMT require intervention. That is a very important statement here, because many of the VMT maintain good visual acuity and mild tolerable metamorphopsia and might not require treatment. Observation, pharmacological vitreolysis has been tried, pneumatic vitreolysis has been tried, and in cases where it increases and the patient vision decreases, that is when the PPV comes into the picture to eliminate the anterior-posterior and the tangential traction, thereby relieving the attachment to of the vitreous to the fovea. So what was the pharmacological vitreolysis? Ochriplasmin was very much approved. It's a recombinant truncated form of human plasmin. Unfortunately, it's not continued anymore because of the severe retinal toxicity. I had injected in 2 patients in Toronto during my fellowship. It's around 12 years back. Only the stage 1 or 2 did have a good improvement, but otherwise it did not. And usually we don't inject in the Fridays because Saturday and Sundays you'll be off, and the patient complains of abnormal loss of vision. Some very distortion and shaky vision is what is complained by the patient. So phase 3 MIVI Trust was the one which first approved this ochriplasmin, but I don't want to discuss more about it because it's not continued anymore because obsolete due to retinal toxicity and also not available in India. So what are the indications of surgery for the VMT? As I described earlier, decreased visual acuity, good visual acuity with severe metamorphopsia, VMT with ERM, and demonstrated progression of the retinal traction. So this is just one of the video I just wanted to show. Oh, I don't have the seek bar. Not seeing the seek bar, toolbar. How should I get the seek bar? Come out of it. Just hide the presenter's view. Okay. 1 second. No, not that. 1 second. Okay. I hope it is seen. No, there it is not seen. Full screen है अभी. Control P. Full screen नहीं हो रहा है. Okay, so now you can see here. So I am trying to peel the ILM over the fovea. See here, so nicely you can see the ILM getting peeled over this foveal reflex. I'll just see bar chala gaya fir se. Okay. Anyway, so this was the case, and then now you can see the post-operatively the patient did very good. And so intraopacity, how does it help in these cases? It can prevent you from going for iatrogenic deroofing that might cause a macular hole. So pars plana vitrectomy for vitreomacular traction. Yeah, arrow nahi aa raha hai. Okay, so pars plana vitrectomy for vitreomacular traction syndrome, a systematic review and meta-analysis of the safety and efficacy showed that ILM helps in complete release of traction and ensures complete removal of ERM. So what are the poor prognostic factors for the surgery for VMT? Could be macular schisis, prominent CME, chronic retinal detachment, premacular fibrosis of duration of more than 6 months. So coming to the next one is the epiretinal membrane. You all know it's the pathologic fibrocellular tissue caused by proliferation of myofibroblastic cells at the vitreoretinal interface. It's a semi-translucent and proliferates on the surface of the internal limiting membrane. So 95% of the ERM are usually idiopathic, that is vitreoretinal traction causing anomalous PVD. or it could be a secondary ERM because of causing the retinal break, or because of the retinal detachment, or uveitis, or trauma, or diabetes mellitus, or many other factors. So this is how you can see here there is a contractile ERM which is trying, and the retinal traction force is almost similar to the retinal fold of depth. So these are the various etiology of the secondary ERM. It's already mentioned in textbook, I'll not go into the details of it. So clinical diagnosis, we can see the blunting of the foveal contour or wrinkling on the retinal surface, and macular edema or the pseudohole can be seen in association with the epiretinal membrane. So this was the case of epiretinal membrane here. You can see the traction. This is a stage 4 ERM, and a post-surgery you can see there is almost restoration, not very, but there is a near normal restoration. So what are the two forces which comes in act here? You can see here this is the centripetal force, where the forces come together, where the edges of the hole come together, and it might look like a pseudo hole where there is a deepening or the straightening of these the foveal edges. Or else it could be a centrifugal force where it is pulled apart. Apart from this, you can see a homogeneous kind of material which is called as the epiretinal proliferation. And this is something like a lamellar hole where you can see there is a tissue loss kind of thing. So these are the two forces which we need to remember, is the centripetal and the centrifugal forces which the ERMs can behave sometimes. But in this, you have an external epiretinal proliferation at the edges you can see here. So what are the OCT classifications of epiretinal membrane? Stage 1, you can see there is a normal foveal preservation. Stage 2 is the ERM and the thickening of the ONL, and there is loss of foveal depression here. Stage 3 is you can see the appearance of the ectopic foveal inner layer, and the stage 4 is complete distortion, loss of foveal depression, and the IFL with anatomy and identification is completely lost. So what are the indications for the surgery? Vision of 6/18 or worse, symptomatic with metamorphopsia, anisoconia, or sometimes based on the OCT also, like higher baseline CMT, presence of ELM disruption and EZ disruption at the baseline. That is when we have to intervene. Otherwise, if we wait more, it can cause more loss of foveal contour, and presence of IFL, that is ectopic inner foveal layers. So this was the case which I am just showing you, the surgical demonstration of the epiretinal membrane. It's a very simple surgery. After doing a vitrectomy, a PVD induction is done. This was the case secondary to the PDR. And you can, of course, with the help of 3D visualization, you can have various color channels if you want, decrease the dye propensity. Now you can see here, I'm just trying to peel around the epiretinal membrane. You can see the negative staining of the epiretinal membrane, which I wanted to show it here. It doesn't stay much, and later on, you can use some dye to really stain the ILM. So sometimes, most of the times, these ILM comes off with the ERM, but in cases where it doesn't come, then you have to always check by doing a restain, because always removing an ILM might decrease the recurrence of the epiretinal membrane. Here, just I'm showing it in a monochrome mode of the Ingenuity filter so that you can appreciate it a little more. You can see the stained ILM is appreciated much better, and then you try to get rid of this as much as possible so that you want to have a least recurrence. So this is the post-op of that picture where you see a near normal contour. Now coming to the lamellar macular hole, there is, as I said, there is a defect in the inner foveal or the irregular contour. However, with the intact photoreceptor layer, this is very, very important. So for the sake of postgraduates, you can describe it as a degenerative macular hole, lamellar hole, where there is ellipsoid zone defects, round-edged cavitation is seen. Sometimes you can see these small foveal bumps, and of course you can see the epiretinal proliferation which I described earlier. It's a medium homogeneous structure which is seen here in between the two hyperreflective layers. Whereas it is called as the tractional, it is also called as the moustache pattern, for you to remember it. In this you have an intact ellipsoid zone here. The sharp edge of the splits you can see here, intraretinal cystoid spaces, and above that you can see the epiretinal membrane here. So please remember, it could be either degenerative or the tractional. Most of the times we observe it, but surgery is required if the patient has significant metamorphopsia, documented decline in vision over time, and associated with VMT bar epiretinal membrane. So sometimes, as described most of the time, the LMH, some authors have described associated with epiretinal proliferation. So how does it differ? These are the things which have poor prognostic factors, and while peeling also, this you can see a yellowish kind of membrane while peeling from the fovea. All care has to be taken because any little inadvertent pull of this epiretinal proliferation can cause a macular hole. So it's always advised to just leave it in between. It is also called as the embedded technique, and just try to leave it in between, and you can just cut it off or better leave it. So lamellar holes with LHEP are more likely to have larger tissue defect, disruption of the EZ if left for a long time, and poorer mean visual acuity. So this is what I was mentioning, is the embedded technique improved the visual acuity significantly outcomes than those with PPV using conventional ILM peeling. So coming to the last topic is the macular hole is a complete break in the retinal tissue. Here's the gas classification of the macular hole. I'm not going to the details. You almost might be knowing about it. So this is again, so IVTS classification, which I'll be a little bit stressing about, is size. Small is less than 250, medium is 250 to 400, and large is described more than 400. Cause it could be primary or secondary, and presence of absence of VMT. So this you can see here, clinical picture. It is a small hole of 126 micron, which is less than 200, 200 to 400 medium, and large, which is more than 400 microns. So it was Eckard et al. Who first described the vitrectomy and ILM peel, and then it was Kelly and Wendell who first published it after getting nearly around 20 to 30 rejections, is what was told in one of the ASRS meeting by himself. And this relieves the anterior, posterior, and the tangential traction, that is complete ILM peeling. So 360 ILM peeling is considered still a gold standard, but however, with the large macular holes which are more than 400, or extra large macular holes which some authors have described as more than 800 or 1000, which leads to complete removal of ILM around the macular hole, was not done, and the remnant was left in place. So this was first described by Zofia, a daughter of Jerzy Nawrocki. So here I'm just trying to show that we published a paper recently using a PFO technique, where doing a multi-layered ILM flap technique. Here you can see here I'm just under the PFO. So what are the advantages is the flaps get stuffed inside the MAC hole, and the accidental flap dislodgement is what is described by Zofia will be very less if you do it under the PFO. So under the PFO, you can see here I'm trying to peel it from various parts and then trying to stuff it. IOCT, you can see it looks almost like there was no macular hole or a closed hole, but definitely it takes time for the hole to close. And here I'm just using doing fluid air exchange and just trying to tilt the eye, get the PFCL off the macular area, and then do it. Otherwise, the flap sometimes might come out because of the active movement of the PFCL while doing a fluid air exchange. And then a gas tamponade was given in this case. So surgical failures, surgical failures are caused by retroversion of the ILM flaps to its original position. There are various other techniques described, that is the temporal ILM flap technique, that is the decreased incidence of Donfill, that is dissociated of optic nerve fiber layer. Here I can just show you in a glimpse. So here I'm just trying to do a temporal flap technique here, where you can just try to take the ILM temporal to the fovea and then just slowly move it over to cover the fovea, the macular hole. And then you can just do a fluid air exchange, and you can see the nice placement of the flap in the monochrome mode. So this is the hole closure in that case. So hole closure is almost 72 in classical. With temporate ILM flap, it is 100%. We had our own study where more than 100 eyes were studied, and type 1 closure was seen in 92.2% of eyes, and statistically significantly improved visual acuity was found after 3 months. So the large macular hole autologous retinal transplantation is the way to go. Now most of the authors have already described about it, where I'm just trying to show you the technique of the autologous transplant, where you can see here, this is the diathermize the area where you want to do it, and select the area where there are less blood vessels so that you don't have bleeding. Some authors say that do the endolaser later, and you saw that I use a 41 gauge needle just to lift a little bit, because I don't want to hit the choroid and cut the RPE. And under PFO, put the PFO, and then you can just slide it under the PFO and just graft overlay over the macular hole. Some authors have described it as the inner lay as well, but I'm just trying to show you the overlay technique of this. So this is the post-op 1 week of this patient, and he's yet to come. So we have done around 24 cases of autologous transplant, and most of them are doing very well. Now, lastly, I want to say that the transplanted neurosensory retina is thicker, contains Muro cells, and what has been described lately is the ectopic synaptogenesis. That means which involves the extension of the bipolar axons to form new connections with the transplanted photoreceptor cells. So last technique is the macular hydrodissection technique, and they have shown a good improvement to be less invasive before going in for a retinal autologous transplant. What you can try, the other technique which is being described is, I'm just using a 41 gauge needle here and just trying to make a macular detachment induction here. So in all the 4 areas you can see, you can just do induce it, but make sure that these bullous detachment come forward. And so what's the rationale here? The 360 attachment of the edges of the macular hole is stuck to the RPE. That is why probably the macular hole is not coming close to each other. So by doing this technique, you need to make sure that there is complete 360-degree lysis of the edges of the macular hole to the RPE. So this is the post-op of this patient. The patient is doing well. So lastly, I would like to end it telling that there are different types of macular hole closure. Type 0 is open mac hole closure, type 1 is closed mac hole, and type 2 is closed with autologous or heterogeneous filling of the tissue is what is described. So what's important here for the sake of postgraduates, MHI, please remember, is a significant anatomical success predictor in cases of the macular hole. So vitreoretinal surface are commoner than we think. It's easy to miss on clinical examination sometimes. OCT is really helpful. Observation is necessary if no visual complaints. However, intervention is required in patients with the visual complaints, and prognosis depends on the type and the chronicity and the parameters. So I'd like to acknowledge my 2 fellows who are helping me in picking up these cases, Rishikesh and Shadma. Thank you very much for the patient listening. Thank you, Extreme Panel. Thank you.